Yes, Dr. Wala. So I've just started the recording as well, and you can begin as soon as you feel ready, and as soon as candidate 1 is ready, please
I'm ready.
please let me know when I should start the timer. Do you want me to keep a timer of 15 minutes? Because that's usually what we do. Or
Okay, doctor.
it's as per you, whatever you wish. It's totally your choice, Dr. Wala. We'll do as
two
per you.
candidate or 4 candidate today?
Only one candidate for you, like one candidate per examiner. Then the second examiner is Dr. Aarushi, and
Yes.
then we'll have candidate 2 for her.
Okay, as you like.
Sure. So you can begin whenever you are ready.
You see my screen now?
Yes, we can. Yes. Everyone else can see the screen, right?
Yes. For me, it will be how many minutes for candidate? 15 minutes or 30 minutes?
If you want to take 15 to 20 minutes is ideal, Dr. Wala. But if you want to take more time, that's good enough.
Okay, I have okay after finish the case. Okay, as you like.
Sure.
Okay. Can I start now?
Please do. Yes.
Okay, so this I'm presented with chest X-ray for a pediatric patient frontal view. I can appreciate evidence of left mid-clavicular fracture, which is slightly displaced. I will check other bones for other fractures. Okay. I can see also evidence of multiple left rib fractures. Some show partial callus formation, so I think this indicates fractures of different ages. I cannot appreciate definite pneumothorax on the provided view. However, lateral decubitus view is the ideal view. Otherwise, regarding the scapula, even I cannot appreciate scapular fractures on this view. So, in summary, there is multiple rib fractures of different ages, in addition to left clavicular fracture. So, I will urgently discuss my findings with the treating physician because I'm suspecting non-accidental injury. I will call the pediatric authority for checking of the possibility of child abuse and recommend the screening for other splints.
Are you sure about the left rib fracture, doctor?
Actually, I saw.
Are you sure? Which rib fracture? Which number?
The left fourth.
Nothing in the rib.
Okay, so nothing. So this is only a left clavicular fracture. Okay. Otherwise, I cannot appreciate
the cause for this fracture.
So if this is isolated clavicle fracture, so this could be due to a traumatic delivery.
Yes.
In this age.
Okay.
So I will.
What is the name of this traumatic delivery? Okay, doctor. Next.
Maybe shoulder dystocia. Okay.
Yes.
Now.
Yeah, it's good. Next.
Okay, this is a brain CT scan, axial cuts without contrast of a relatively young patient. The striking finding is a well-defined, rounded, hyperdense lesion centered in the midline at the third ventricle. So I can, and there is a slight. I would like to check the other sequences to check for the hydrocephalus and the post-contrast images as well. So,
can you give the different diagnosis for this case?
Yes. So my provisional diagnosis is a colloid cyst, intraventricular colloid cyst, and less likely aneurysm, but this is a typical location of a colloid cyst. So I would like to check other sequences and to convey my
Regarding
findings.
the size, colloid cyst is big, large, no definite obstructive hydrocephalus proximally.
Mm.
It's middle age female and present with headache. Acute onset of headache.
Okay, so if this is not on other sequences, if this is not intraventricular, so this could be an aneurysm of the basilar artery.
Yes.
Since it's hyperdense, however, I cannot appreciate definite peripheral calcifications. Also, I would like to check the post-contrast images, and regarding the headache, I would like to check the subdural or the blood window to check for possible associated subarachnoid hemorrhage, for possible rupture of the aneurysm. And I would like to recommend
any other different diagnosis would you like to add beside the aneurysm?
This could also represent a cellular/supracellular mass. So I would like to check the sagittal images to check the pituitary gland and the extension of the mass.
Okay, you would like MRI sagittal. Which sequence?
Yes.
Which
T2.
sequence? I have T1, okay?
Okay. Okay, so this is sagittal T1 images without contrast. For the same patient, the mass appears hyperintense, and it's cellular and supracellular with compression and upward displacement of the optic chiasm.
Yes.
I would like to see the coronal images to confirm the midline location and the T2 to confirm the signal on T2 and post-contrast. However, this is a young patient, this may suggest I have two possibilities actually, either cystic craniopharyngioma or a Rathke's cleft cyst.
It's intracellular or supracellular lesion?
It's combined intracellular with supracellular extension.
Yes, and the signal in T1? High signal.
Hyperintense.
So your diagnosis, what?
It's most likely a Rathke's cleft cyst.
Cleft cyst?
Rathke's cyst, yes.
As a cleft cyst, it should be fluid.
Yes, Rathke's cyst sometimes hyper on T1, but okay, this also could be a cystic craniopharyngioma, I think, or if it's suppressed on stare, this could also represent a dermoid. So I would like to check the stare images.
Next.
Okay, here this is a frontal view for pelvis X-ray in a skeletally mature patient. I'm starting to check the bones. Okay, I cannot appreciate any definite fractures. In my routine practice, I would be accessible to the patient's history. However, no definite fractures, no definite bony lesions, but the right femur head appears to me that is slightly irregular with sclerosis, slight sclerosis. And with irregular articular surface. So this may be a case of right femur head vascular necrosis. I will check the left femur head is unremarkable with preserved height. I will check if there's a possible an evident cause on the image. I cannot appreciate H-shaped vertebra or transplanted kidney. I will check also for the
what is the next step?
Stones. Okay. Next step. I will discuss the findings with the treating physician and ask if the patient is a known case of any medical disease or if he's on steroid or alcoholic. And I will, regarding the imaging, I would recommend the MRI to check the
MRI. You see, describe the finding.
Okay, so this is T2 coronal sequence. As we said, left femur head is unremarkable, and the right femur head showed sclerosis, irregularities with the hypointense areas suggestive of sclerosis. And
what is the percentage of bilaterality of avascular necrosis in both femur head?
I think 30%, but I'm not sure.
Okay.
and there's also fluid. Okay. So this is the chest X-ray frontal view for a skeletally mature patient, adult female patient. I can appreciate pumpy enlargement of both highly. They are almost symmetrical enlargement, in addition to thickened right paratracheal stripe. Regarding, I cannot see any calcifications within the hilar lymph nodes. Regarding the lungs, I can appreciate faint reticulonodular shadowing. That's mainly at the middle zones. Right costophrenic angle is clear. Left costophrenic angle is not much appreciated. Could be slightly blunted. Otherwise, I cannot see any cavitary lesions, consolidations, or pneumothorax on this view. So my provisional diagnosis is a case of sarcoidosis. I would like to discuss the findings with the treating physician, ask if this is a known case of sarcoid and compare with previous images. And if this is a new diagnosis, I would like to order high-resolution CT scan for the patient.
CT.
Okay, so this is high-resolution CT scan for the same patient, axial cuts, showing nodular pattern in peri-bronchovascular and peri-lymphatic nodules, mainly peripherally, and also within the fissures.
Yes.
Along the fissures, there is also evidence of peribronchial thickening. I would like to check the hilar areas to check for any complications like conglomerate fibrosis.
Okay, what is the lab test for sarcoidosis, doctor?
ACE inhibitor.
And definite diagnosis by what? How we can do definite diagnosis by what?
I'm not sure. I cannot remember the name of the test. It's something like this from the screen. I'm not sure. I cannot remember the name actually.
Okay. Next.
Okay, so this is ultrasound image of the liver, showing evidence of a transverse scan showing evidence of hyperechoic lesion. It's relatively defined, at least its anterior border, seen in subcapsular location. Hyperechoic
diagnosis, doctor.
So hyperechoic hepatic lesion could represent hemangioma as the most common one, and I can see that what's visualized of the hepatic outline is normal, so less likely to suggest HCC. However, fibrolamellar HCC could also be differential since it's present in non-cirrhotic.
Are you sure this is hepatic origin or in other place?
Actually, I can appreciate the hepatic capsule outside the lesion, but I would like to confirm on other views. If this is an extrahepatic, it could be arising from right kidney or right adrenal gland. So I would like to check others. If it's of adrenal,
adrenal,
yes, it could be myelolipoma.
So and next step.
CT scan, triphasic of the, including the adrenals, or the MRI.
Okay, you can see MRI, this T1 and T1 in phase and T2.
Okay, so yes.
Sorry, doctor, I can't hear you.
Now I'm audible?
Yes, it's okay now.
Okay, so this confirms the hepatic location of the lesion seen at the anatomical location of the right adrenal gland. It shows high signal on non-contrasted images, and on contrast.
This in T1 on the left side,
yes,
T1 in phase, T1 in phase, other one T2. Do you like to see any other sequence?
I would like to see the out of phase to check the signal drop.
Sorry, doctor, I can't hear you.
I would like to see the out of phase images.
Okay, I have a fat set.
Okay, so on FAT-SAT, the lesion shows the drop in signal intensity, confirming the fatty components of the lesion. So this supports the provisional diagnosis of myelolipoma of the right adrenal gland.
What is the complication of this renal myelolipoma?
This could be complicated by hemorrhage, especially with the large size of the lesion.
Okay.
So this is an elbow X-ray for a skeletally immature patient, no side marker on the image. I can appreciate a valved lateral humeral epicondyle, since it's seen away from its anatomical location. So on lateral view, I would like also to check for the associated effusion or any other associated fractures.
Dr. Next.
Okay, this is a barium follow-through study of a skeletally immature patient. A contrast follow-through study of skeletally immature patient. The stomach is distended. I can see contrast within the bowel loops. However, the right duodenojejunal junction is seen to the right of the spine, and also the ossified jejunal loops are seen to the right of the spine. So I am suspecting malrotation for this patient. I cannot see an evidence of corkscrew appearance to suggest associated volvulus. However, I would like to correlate clinically for any abdominal pain and convey the findings with the treating physician.
Okay, next.
Okay, this is
time with acute onset of abdominal pain.
Acute onset abdominal pain. Okay, CT scan with IV contrast, without oral contrast, axial cuts showing evidence of the fluid-filled dilated small bowel loops, and evidence of right-sided Spigelian hernia containing a bowel loop and with the indentation of the bowel loop entering the hernia. So this is likely the cause of the obstruction. I can also appreciate some fatty stranding within the around the hernia and the subtle small amount of fluid. So this could be a complicated or incarcerated hernia. Otherwise, I can appreciate some asymmetry of the left gluteal muscle with fluid attenuation, which could represent a collection or fluid density within the left gluteus. So I would like to check other images, especially coronal, to confirm the transition point, and I would like to check the lung window to check for free air or to suggest any perforation. And I would like to discuss the findings with the treating physician, urgently refer the patient for the surgical team.
Okay, next.
Okay.
Adult patient came with chest pain.
Okay, this is a frontal view for skeletally mature patient. I can appreciate a lytic lesion involving the distal left clavicle. The lesion is slightly expansile with relatively wide zone of transition. No evidence of soft tissue extension or cortical breakthrough. I cannot appreciate any soft tissue swelling or the extension within the mass. So in a skeletally mature patient with a single aggressive looking lytic lesion, I may suggest metastasis. Although I cannot see any other lesions on this view. Other differential could represent plasmacytoma or multiple myeloma and lymphoma.
What is the next?
So I will discuss the findings with the treating physician, and if this is a new diagnosis, I would like to further evaluate this by MRI and order skeletal survey for any other lesions. organ
Okay.
scan.
Okay. Next. This patient came with acute onset of scrotal pain, left
Okay,
side.
so this is the focused ultrasound image at the left inguinal region. I can appreciate evidence of skin thickening with underlying fluid streaks indicating edematous changes. In addition to this, I can see multiple coarse, irregular hyper-echogenic foci that exert dirty shadowing. So this is for me. This represents air locules. So there's in summary, there's evidence of skin thickening, inflammatory changes in addition to air locules in a patient with who acutely presented with left scrotal pain. So I'm suspecting necrotizing fasciitis. This is an emergency. I would like to convey the findings to the treating physician. And
is it any other name for this necrotizing fasciitis specific for this place?
For Neyer's gangrene.
Yes. Okay.
Yes, and compare if there's previous X-ray to check for the air.
Okay, this patient came with lumbar pain.
Lumbar pain. Okay, so this is ultrasound scan at the level of the kidney in a patient who presented with lumbar pain. I can appreciate a well-defined oval-shaped hypoechoic abnormality seen at the left lumbar region, showing a few areas of a few echogenic foci, and also some anechoic areas. So I would like to check the okay, here the measurements. I would like to check the Doppler images if available, and
nothing in the Doppler.
Nothing. So it's hypovascular. So this may represent could be an abscess or a collection in this region.
You expect where is the abscess?
It's in the I think pararenal space, or could be at the
next step. What do you want to see?
CT scan with IV contrast.
Okay. Other image, you can do MRI.
Yes, also on that.
MRI.
Okay, on MRI, it's seen expanding the right psoas muscle. So it's a collection inside the psoas with the surrounding fluid and fatty stranding. I can also appreciate hyperintensity within the two contiguous lumbar vertebrae and their intervening disc. So this could represent spondylodiscitis complicated by right psoas abscess formation, and there is also a subtle hyperintensity within the left psoas, likely due to the inflammatory process. So I think this could represent a TB spondylodiscitis, which is a Pott's disease. I would like also to check the left kidney since it appears atrophied to me. So there could be an involvement of the left kidney by the TB.
What is the next step?
I would like chest X-ray to check for the lung involvement and to urgently refer the patient for surgery or interventional radiology for possible evacuation of the abscess, and neurosurgery for treatment for the spondylodiscitis.
Okay. Next.
Okay, lateral skull X-ray for a skeletally immature patient. Okay, I can appreciate a lucent lesion at the frontal bone, and another one seen at the parietal bone. So this could represent histiocytosis or eosinophilic granuloma. Other differentials could include a neuroblastoma metastasis I can also appreciate cortical disruption, but this is the region of
Is neuroblastoma metastasis or eosinophilic granuloma?
most likely eosinophilic granuloma because of the age of the patient and the beveled edge of the lesion. So I would like to discuss the findings with the treating physician and check for other bony involvement.
Like what would we see in the bone?
I can see involvement of long bones with diaphyseal lesions, vertebra plana in the spine, and also kissing sequestrum within the spine.
Anything in the chest would you like to see?
Yes, the chest involvement in form of multiple nodules and cysts. The cysts are irregular, bizarre shaped with sparing the costophrenic angles.
Okay.
And
do you know any lab test specific for this condition?
Lab tests for I don't know actually.
Okay, next.
Yeah, sorry to interrupt you there, Dr. Wala. I think after this case, we should wrap up for candidate 1 because we're already 25 minutes past 11 in India.
Okay.
Yeah, thank you.
So I will start with this or?
Yeah, you can complete this case and then we'll wrap it up.
Okay, this is the axial cut CT scan of the abdomen showing evidence of abdominal aortic aneurysm with peripheral calcifications. The aneurysm shows, in addition to adjacent collection of hyperdense fluid suggestive of hematoma. Also, I can appreciate interruption of the calcifications at the right posterior aspect of the aneurysm. So this is likely ruptured abdominal aortic aneurysm. I cannot appreciate the IVC here. To check for the possible fistulation with the IVC and or if it's slit-like to check for the evidence of hypovolemic shock within the patient. I would like to check other sequences to confirm these two complications, and I would like to urgently refer the case for vascular surgery for stabilization of the patient and possible intervention.
Okay. I can complete also only 2 cases, doctor, to complete 15 cases?
Sure, you have 2 more cases left, is that it?
Okay.
Yeah, please go ahead. You can complete the cases. Yeah, sure.
Okay, this is frontal chest X-ray for a skeletally mature patient. I can appreciate a left hilar mass, a left mediastinal mass. The mass shows is a well-defined with no calcifications or cavitations seen within. I can appreciate the hilar vessels through the mass. So this is a positive hilar overlay sign indicating that it's of none of hilar origin. However,
is anterior or posterior mediastinal?
I will check. I'm checking the aortic. The descending aorta, which is not appreciated, so I think this is a posterior mediastinal mass. I would like to confirm with lateral view.
Okay, we can CT. This CT?
It's anterior on CT. Okay, on CT, the mass is silhouetting the aortic arch, so it's anterior in origin, and it's homogeneous, enhancing.
What's your diagnosis?
It could represent, according to the age of the patient, it may represent a thymoma or...
This patient came with a change of voice. Do you like to check anything?
Yes, I would like to check the vocal cords for possible invasion of the recurrent laryngeal nerve, especially with the change in voice for the patient.
This is the vocal cord?
Yes, here I can see medial bowing of the left vocal cord, giving the sale sign. So the mass is invading the left recurrent laryngeal nerve, causing hoarseness of voice. I would like to convey the findings to the treating physician, discuss an MDT, and refer for thoracic surgeon as well as ENT specialist.
Last case.
Okay, bilateral knee X-rays, frontal views for skeletally immature patients. I can appreciate two lesions at the right distal femur and left proximal tibia. The lesions show similar characteristics. They are metaphyseal, sparing the growth plates and the epiphyses, mainly of ground glass density, ground glass matrix with some septations. And some expansion of the bones.
Can you give different diagnosis, benign or aggressive lesion?
For me, this is a benign lesion with narrow zone of transition. And regarding the multiplicity, I'm thinking of fibrous dysplasia, polystotic form. So I would like to check.
Any other different diagnosis?
Others could represent. Could represent. I'm not sure actually. Could be EG, but EG can come in many forms and could be multiple, but it's less likely since it's more diaphyseal. Multiple.
If this patient has chronic renal disease.
Renal disease. So this could represent brown tumors in secondary hyperparathyroidism.
Yes. We have ultrasound for his kidney. What do you think?
Okay. This is bilateral medullary nephrocalcinosis in form of echogenic foci within the medullary pyramids. So this is a case of medullary nephrocalcinosis caused by hyperparathyroidism. I would like to check also if there is neck ultrasound for parathyroid adenomas or hyperplasias or by systemic scan.
Okay. Thank you, Doctor.
Thank you.
Yeah, thank you so much, Dr. Wala. What we can do is go through the cases again. Yeah, Dr. Wala, you still there? So we can just discuss the cases and the answers, and you can probably give a feedback to candidate 1.
Okay. 1 minute, Doctor.
Please, yeah. Meanwhile, candidate 1, please stay with us, and candidate 2, kindly get ready. So we'll start your viva in 2 to 3 minutes. Yes, Dr. Wala, we can see your screen and the case 15.
Okay. Start from start. First, this case, all my viva case in the last exam in June. This typical case I see. So the doctor is very good, and he answer all cases very good. I have still many cases. For other viva, I have 30 cases, so I will complete it later, inshallah.
Exactly. Sure.
Regarding this patient, right left clavicle only fracture, you say there is posterior rib fracture, but nothing. You should also add non-accidental injury, as you said, and also you can add the different diagnosis, osteogenesis imperfecta, but less likely as no evidence of bony osteopenia. So, in view in only clavicle fracture, as you said, there is burst injury, as you said, shoulder dystocia. Other one, this cases, this is the only case you did it wrong, but it's very easy. This is the pituitary macroadenoma with hemorrhage, pituitary apoplecticity. So the patient came with acute onset of headache. It's mainly intracellular with supracellular extension, high signal in T1. It's an easy case, but no problem. All other cases you are very good. This case of vascular necrosis, you said right. You can say in view of the image, I would like to check the sacroiliac joint, to rule out sacroiliitis, as rule out the steroid therapy. Also, you said I can see H shape. I would like to ask about the history of sickle cell. All things you said Correct. That's good. This sarcoidosis, lab test angiotensin converting enzyme inhibitor, and the definite test by biopsy, transbronchial biopsy. If you do biopsy, transbronchial biopsy, because you have hilar lymphadenopathy. This pre-lymphatic nodule, as you said. This lesion, you said the hemangioma, adenomyolipoma. All other things. This one, you said right. I would like to check the all image to rule out any sign of bowel ischemia, like pneumatosis intestinalis, portal venous gases. I would like also to check mesenteric vessel. You should say that mesenteric vessel to rule out any vascular thrombosis.
Okay.
This lesion, aggressive lesion, you see the cortex here, it's not appears, the cortical disruption. So it's aggressive lesion in adult patient, first possibility metastasis. You can say in the first, I would like to ask about the clinical history. If there is history of primary, there is the metastasis. If no history of primary, I would like to recommend to CT chest, abdomen, pelvis to rule out the site of primary.
Okay.
This for ganglion, as you said, this one is difficult. You said right, this fluid collection, mostly abscess, as no vascularity inside. Eosinophilic granuloma, as you said. This lab test, I asked about the lab test. I don't know actually the lab test what, but I asked later. It should be CPC. You can see in CPC the differential account of pulmonary blood eosinophilia and pulmonary Langerhans cell, something like that. Should be CPC.
Okay.
Retroperitoneal hemorrhage, as you said, it's urgent case. I would urgent to discuss with vascular and intervention. This anterior mediastinal mass, you cannot see the mediastinal border. Here you cannot see the mediastinal border, so it's mainly anterior mediastinal mass.
Okay.
Last case, brown tumor. Don't forget brown tumor in any case with multiple lytic bony lesion, mainly if it's expansile. And we can, in middle age, in young age, in adult age, any case with multiple lytic bony lesion, we add metastasis, we add multiple myeloma, and also brown tumor. Don't forget brown tumor. We would like to check kidney. We would like to check the parathyroid adenoma to exclude brown tumor.
Okay.
Anyhow, all cases very good. Yeah.
Thank you. So this is not a ground glass matrix, right?
There is mild ground glass, mild expansile, but you see there is a lesion metaphysis mainly, and not take all length of the aphysis. There is stipulation inside, not typical for fibrous dysplasia, but you should add fibrous dysplasia and different diagnosis. Should also put the brown tumor. Don't forget brown tumor.
Okay, thank you. Thank you, Dr. Wala.
Welcome.
Thank you, Dr. Wala, for conducting this Viva 1. And candidate 1, please stay with us. I have a few tips for you. Meanwhile, Dr. Wala, that is an excellent way of conducting the Vivas with the strict tone and the optimal speed, and very apt set of cases that you have. And since you told me that you have 15 more cases left, so we can plan another session with you. And I'm sure that all the members of the group will find it extremely useful. So thank you so much again, Dr. Wala.
Welcome, doctor. I would like to say something, but in Viva case, try to spot diagnosis quickly and describe it quickly to and give short summary about the other negative and the next step, because no time in Viva. You should see many cases. If you see many cases, you can pass easy. So try to speak quickly and spot quickly, and that's better. Yeah. Thank you.
I agree. That is a very good tip. And candidate 1, you actually did very well, especially with this point. You tackled around 15 cases in 30 minutes, so that is good speed. And I'll give you a brief feedback for you. So I would mark you a 7 out of 8. That is a good session. And your plus points are that you're fluent, you're very verbal, you keep on speaking even if you're not finding anything important to say, but you're actually very verbal. You're talking, you're discussing with the examiner. So it is a 50-50 discussion. That is good. And your knowledge is up to the mark. Your speed is good. You do not panic. Your approach is perfect. And you do not give in to the satisfaction of search. So if you have found a certain diagnosis, you're still looking at other findings. So this will help you a lot especially in the long cases where you'll have more than one diagnosis. So that is good. So keep it up. And regarding the negative points that I think are that you should compare with the previous radiographs, or at least say that you are going to compare the findings with the previous radiographs. You can say that. And you can be a bit louder. Maybe today you are not loud enough. Maybe there's something wrong with the internet connection. So that may happen in the exam also. So always be ready. If the examiner asks you to be a bit louder, be ready to increase your voice a bit. One more negative point is, in most of the cases, you're not giving the pertinent differential diagnosis. So for example, the case that you thought was a colloid cyst of the third ventricle, since you've been given only one image to deal with, either you can ask an examiner to show you the rest of the images, or maybe give a set of differentials before committing to a single diagnosis, because in that case you went totally wrong.
Yes.
And suppose if you're having any difficulties in a particular case, so always be ready to ask for more images, or maybe the further imaging, maybe the CT scan or the MRI, whatever is applicable in that particular case. Always be ready to do that.
Okay.
And the last thing is that in 50% of the cases, you're completing the case with the management. But in the later cases, Dr. Walla had to actually ask you what you're going to do as the next step. So that should not be the case in the exam. Try to complete it without being prompted.
Okay.
And there's one last thing, that is, you use the word EG for eosinophilic granuloma. Avoid any abbreviations in the exam. Any abbreviations. Other than that, you're perfect. 7 out of 8 I would give you. Very well done.
Thank you.
Very good viva. So we move on to the next viva. So do we have candidate 2 ready, and do we have today's examiner, the second examiner, Dr.
Yes.
Aarushi, ready?
Hi.
Yeah, so Dr. Aarushi, I will make you the host, and it's all to you now. Just give me a moment. Yeah, candidate 2, are you ready? Are you
Yes.
here with us?
Yes.
Yeah,
Yes, I'm ready. Thank you,
Dr.
Doctor.
Aarushi, you are the host now. Over to you.
Okay.
Thank you, Doctor.
Can you guys see the screen?
Yes.
Okay.
Thank
great.
you. Okay, this is an X-ray for a skeletally mature patient. I can see there is medial, there is malalignment of the interphalangeal spaces, the distal and the proximal interphalangeal spaces, causing subluxation. More markedly at the first thumb, the distal interphalangeal joint, it appears subluxated. And however, I can't see any definite bone erosions, and the bone it appear. However, I'd like to see the orthogonal view. Okay. In the other view, I can see that there is subluxation. However, there is no definite bone erosion. Our articular bone appear normal. And in these cases, it could be systemic lupus erythematosus that causing this. I will see the other hand also to see if there was any systemic involvement, not post-traumatic or.
There was no history of trauma. Can you also describe the deformities seen, please?
Yes. I can see this is the left hand X-ray. I can see at the distal interphalangeal joint, there's like ulnar subluxation and deviation. Ulnar subluxation and deviation. And however, the bone appear normal. There is no fractures, and the joint spaces are preserved. And
Okay.
no.
Could you just summarize your findings?
Since it's affecting both hands, we are talking here about systemic disease, and there is subluxation and malalignment of the more markedly of the distal interphalangeal joint. So I think I will put systemic lupus erythematosus on top of my differential. I will correlate clinically, and I will refer it to a rheumatological physician for further investigation.
Okay.
Okay, can I ask for the remote control? Oh. Yes, please.
I've given it to you.
Thank you. Okay, this is a CT scan for a skeletally immature child, post-contrast study. I can see there's effacement of the sulci, loss of the gray-white matter differentiation, and giving the pseudo-subarachnoid because of the diffuse edema, giving that the vessels are more prominent. And I see that there is cerebellum appear white with respect to the cerebrum. So I think of the cerebellar edema, hypoxic ischemic encephalopathy, or due to the prominence seen at the both frontal lobes could be due to benign enlargement, the BIS or hygroma. And I would like to see the bone window also to rule out if the patient have any cause of this brain edema, if the patient has any bone fractures or non-accidental injuries. Okay. I'm checking now the bone window to see if there was any fracture or any cause for the cerebral edema. Those are bilateral symmetrical, consistent with sutures. However, here I can see there is a depressed left parietal fracture. So if the patient has no history of falling down, I'm worried of non-accidental injury. I will do a skeletal survey to assess if there was any posterior rib fracture or metaphyseal corner fracture of both femurs or anything specific, and I will alert the security and for.
So what are you thinking about the collections? Do you want to go back to the basic things?
Yes. It could be a chronic hemorrhage causing effacement of the sulci because.
So after the skeletal survey and the CT brain, if you're finding something abnormal, what would be your next step?
I immediately alert the security protection of the child for I will be worried of non-accidental injury. I will also screen his siblings, and I will take the two opinion of both radiologists because to confirm non-accidental injury, and we will do a follow-up and brain MRI and spinal MRI and abdomen and pelvis ultrasound also. Okay, on the brain MRI, I can see there is a bilateral subdural hyperintensity seen in both frontal, extending into the interhemispheric. And I would like to see on T1 to see the staging. On T1, I can see that the left appear iso-intense while the right appear hypo-intense. So we are talking about different stages of blood. The left one, it could be hyper, we're talking late subacute, and the other one chronic and hypo about chronic cystic changes. So we are talking about different stages of blood. So it confirmed the diagnosis of non-accidental injury.
Anything else in the brain scan that can basically, why are we doing the MR? Anything else in the brain parenchyma that you can comment on?
Yes. I would like to see if there is SWI to see if there was any microhemorrhages. I will see if this edema or the effacement of the cell side that was seen here, it most likely due to the mass effect of the edema causing the effacement. If there was any brain herniation due to this mass effect. However, I can't see any crowding of the foramen magnum or any ankle or shift of the midline structures. I can't see an intraparenchymal brain hemorrhage. However, I would like to see the SWI to confirm any microbleeding. And the left previously seen fracture was at the left parietal.
Okay.
And there is a...
1 second, it's fine. Can you please stop scrolling? Thank you.
Yes. Okay, this is an OPG for the mandible. I can see there is a fracture line seen at the right mandible angle. I would search for other fractures since usually closed ring cause more than one fracture. And I will see the underlying bone. It could be a pathological fracture rather than just a fracture because there is an extensive soft tissue swelling seen at the right angle. So it's most likely there is an underlying bone lesion superimposed with this pathological fracture. And there is a deformity seen at the right of the bone at the right angle. So aggressive lesion of the mandible superimposed with right mandibular fracture. It could be if he was an adult metastasis or lymphoma. If he was a child, I'm worried about or it could be I can see
the particular on this radiograph, which is going to help come to a conclusion essentially as to the underlying cause of the pathological fracture.
It's a soft tissue.
Can you point out the soft tissue for me, please?
Yes, this whole.
I can't see your mouse.
I can annotate. Maybe like this.
Okay, great. So can you comment on the dentition, please?
Comment on what? I want
on
to clear
dentition.
This.
On the pattern of the dentition of the patient. Basically,
yes, they appear lost at the site of at this side. It could be due to an also infection, osteomyelitis with abscess, and because osteomyelitis also give an aggressive appearance. It could be a collection abscess and superimposed with this because there is
a possibility of connection of the upper and lower jaw to an abscess. How would an abscess migrate from the lower to the upper jaw? Anatomically speaking,
through the foramen.
That's all right.
I can.
So there's a 30-year-old male presents with a history of trauma. 30-year-old female presents with a history of trauma.
Okay. This is a CT scan with IV contrast. I can see, I will have a general look first. I can see there is Okay. I can see there is enlarged IVC. However, I would like to see the port to venous phase and the venous phase for better evaluation. Or it could be a lesion which is compressing the IVC to appear enlarged. However, the left renal vein is draining. I will see other spleen. Usually, I don't comment on the arterial phase. The liver appear hypo-enhancing. Okay. So they have hyper-enhancing of both kidneys, more marked, and
I want you to scroll from top to bottom again, please.
it doesn't move more than this. Is this the final image? This one? That's
One
it?
second. Okay, start again.
Okay. Okay. I will have a general look first. Okay. I think that is the
Can you
end of
focus
this.
on the chest sections, please?
I see the mediastinal window now. I will assess the vascularity, the brachiocephalic and its branches, and the pulmonary artery. However, there is no definite filling defect is seen. However, I would like to assess the pulmonary with its window, the CT pulmonary angio. However, in this, I can't see.
Okay, so
Any,
once we've ruled out the
compass?
mediastinum is okay, since this is not the lung window, we've seen that the lungs are okay. What is the third compartment that we look at?
And I see the muscle at the right side, the pectoralis muscle appear not absent. So it could be a Poland syndrome. I will see other association with Poland, like breast and thumb absence. Okay, this is a CT scan, non-contrast axial. I will take the general look first. Okay. I can see there is at the frontal sinus, it appear hypodensity felt with a bone defect seen at the frontal and soft tissue swelling. And there is also at the intracranial part a bone defect. I would like to see the soft tissue to assess more markedly the soft tissue component, because it could be frontal sinusitis causing bone osteomyelitis and abscess collection, like Potts-Poff syndrome. Okay, here on the soft tissue, I can see that there is hypodensity. The frontal is sinus is filled, and there is hypodensity, and there is also bone erosion seen at the frontal sinus with soft tissue component. And there is also, I will see if there is any intracranial extension. I will ask for a post-contrast brain MRI to see if there is any pachymeningeal enhancement or intracranial extension, and to assess the sinuses if there was any thrombosis as a complication. So I think that's Potts-Poff syndrome. This is a chest, and I will alert the referring physician immediately because this is an emergency, so it won't affect the eye and cause subperiosteal abscesses and proptosis and affect the eye. This is a chest radiograph for respiratory mature patient. I can see there is a soft tissue mass seen superior in the superior mediastinum, extending above the clavicle. extending above, so it's superior. However, no definite mass effect seen on the trachea. I can't see other lung lesion, pneumothorax, pneumoperitoneum, or pneumomediastinum, and the bone appear normal. So I will ask for a thyroid ultrasound to rule out a goiter extending to the superior retrosternal extension, because there's connection with the neck. Okay, this is a brain MRI. I will have a general look first. I can see on the T1 sequence, there is a hyperintensity seen at the right temporal lobe. And there is also edema surrounding it, causing loss of the sulci, and extending into the right sylvian fissure. And I will see the T2 and the diffusion restriction, if I can, please. Okay, it appears here hyperintense on T2. It appears hyperintense on T2. At the right temporal lobe and extending into the right sylvian fissure and causing also cortical edema. I will see the diffusion restriction to rule out. I'm thinking it could be herpes encephalitis because it's causing the right temporal lobe and it's preserving the basal ganglia. Okay, on ADC it looks low, and on diffusion, okay, let's see this one. Okay. There is areas of hyperintensity on WI. I would like to see the ADC. However, the lesion itself, the area itself appear hypointense. So I think the restricted part was the blood component. I thought it would be a herpes simplex encephalitis complicated with hemorrhagic transformation. However, they usually do diffusion restriction. And here I don't see a definite diffusion restriction at the right temporal region. And I thought of MCA infarction. However, MCA infarct usually do cause diffusion restriction. So,
okay, it's fine.
I'll ask for post-contrast to see if there is any underlying lesion. Okay, on post-contrast study, and there is mild or there is no appreciable enhancement. Could be a low-grade tumor, which doesn't show any enhancement or restriction with superimposed blood. Or it could be, and if the patient has history of trauma, a traumatic blood or underlying vascular. And encephalitis usually cause diffusion restriction, variable, cerebritis, the cerebritis.
That's it. Don't worry about it. So if you had to give me two differentials, what would you give with this picture?
Okay, it could be low-grade tumor or blood, or if the patient have cerebritis, if the patient has no underlying trauma or any history of any, so just the blood or vascular cause of the blood.
That's fine. Okay. I'm going to start with the feedback now. So I think you handled the cases really well. I'll give you a couple of pointers as we go through. So in a case like this is actually a case of SLE. You picked it up beautifully. My only complaint or a problem that I think that you could improve on in this case would be, or where I was trying to get at is, when you can see obvious deformities such as swan neck and boutonnières, instead of just giving a generalized name here, it would be better to get your brownie points in by saying on this projection, there is hyperflexion or hyperextension of the distal interphalangeal joints, giving it the appearance of a boutonnieres or a swan neck, respectively, right? So always mention that. So this is actually a case of SLE. You picked that up really well. So the classical feature in this is that the joint spaces are preserved and there are no erosions, which you mentioned. So this is known as reversible deformities of the SLE. Because the moment, because this is because of ligament laxity. So the moment you get the patient to do a PA view, the deformities seen on the lateral actually just disappear. Like on this view, you can't see any deformities, right? So reversible deformities, you handle this one well. Coming to this, so the white cerebellum sign that you were mentioning about the hypoxia, you know, that's usually, it's also a sign of brain death. So be very, very careful when you are giving a white cerebellum sign. In retrospect, can you see the enhancement of all of the vessels of the brain parenchyma really well?
Yes.
So we should not use that sign lightly. Be careful while using those. Also, you picked up the fractures really well. That wasn't an issue at all. So this is a case of NAI. What I wanted you to pick up on the MR, number one was, of course, the age of the infarcts, the age of the subdural bleeds. Also, can you see the foci of altered signal in bilateral occipital regions?
Oh, yes, yes. I
There
know
are
at the
cerebral
end.
contusions. There are cerebral contusions in this, right? It is also seen, it's better, it's also seen on the T2s. Can you see the area of hyperintensity involving the white matter here? So there are cerebral contusions. Once you have this plethora of findings wherein you have one fracture, you have hemorrhages in different stages, you're quite certain of NAI. I like the management of NAI that you gave me, which is just for everybody's referral. You do a skeletal survey. If the child is less than 1 year of age, you do a CT brain. If there's an abnormality, in 2 to 4 days, we do an MR brain. We inform we have to have 2 radiographers who are specialized pediatric radiographers to carry out the skeletal survey. We have to have 2 pediatric radiologists report these cases within 24 hours from when they have been carried out. If there is a sibling, then the sibling should also have a skeletal survey which should be performed. But other than this, you handle this case well. Moving on to this, so I'll show you the pre-fracture image. If I was to just give you this, what I was trying to get you to come to a conclusion is that you already made a diagnosis of a pathological fracture. Now, why is there a pathological fracture? Do you notice that all the teeth only on the right side of the jaw are missing superiorly and inferiorly? And the bone abnormality is also, again, limited to the area which you very correctly pointed out with your cursor. Right? So this is a case of osteonecrosis of the mandible. So why is this happening? This is because of a radiotherapy which has been done. So radiotherapy is, it's done through a port, and it's focused on the area of where the tumor lies. That's why the abnormality in the dentition and the mandible is only limited to the zone wherein the radiotherapy was conducted.
Okay.
So that's why the area of sclerosis and subtle lysis is only limited to this side. That's why the teeth only on the right side are missing. If the patient had a bad dentition, then that should have gone through and through to both sides, right? It should not be limited to only one side of the jaw.
Yes. But why have the patient have a radiotherapy?
So there's probably a history of cancer, an oral cancer for which radiotherapy would be given.
Head and neck. If there is a head and neck, not necessarily to be a bone.
No. A head and neck squamous cell carcinoma is treated with a radiotherapy. Like you'll do an excision followed by radiotherapy in such cases, right? This is a typical appearance of osteonecrosis of the mandible. And this, as you correctly pointed out, is a pathological fracture. The term should always come through, the word pathological fracture. Okay, also in this X-ray, while you were talking about it, you said if this patient was an adult. I don't think there's doubt about the age of the patient in this case. So I mean, there's no point going into differentials of what would you call this if this was a child when you're presented with an adult case. You would rather stick to the differentials, which would be relevant to this case because time is of absolute essence.
Yes.
Moving on to this one. Okay, so you really just went around the bush in this and you just kept focusing on the abdomen. So you don't have to comment on the spleen in this case. Okay, I understand. I think the history threw you off. That's why I purposely left the history just in this one case to make you guys think outside of the box and always look at the image in its entirety, right?
Yes.
Now that you're looking at the image, it's very obvious that it's a Poland syndrome. But I think, we developed a really conal vision when we are assessing things in the exam. So it's very important to keep an open mind. When you're not finding an abnormality, let's not cook up abnormalities by, you were beating about the bush, talking about the spleen, saying, I don't comment on the spleen and arterial. Well, then let's not comment on it. Right? There's no point. We're wasting time. And the liver is not hypoenhancing. It's just the arterial phase. So this is adequate because you've seen the vessels. So I kept trying to tell you, see the other images, to see the other images. And, the examiner talks really less during the exam. So whatever the examiner says, hang on to every word that he or she says. Because they are never trying to mislead you. They're always trying to guide you to help you get to the final conclusion. So I don't think we'll miss Poland's in the future.
Yeah.
This was a pot puffy tumor. You handled this beautifully. So in this one, the only thing that I would like, that I noticed was you immediately asked me for a different window in this. So in an exam, you earn the next set of series, or you earn an orthogonal view, or you earn the next image. So before you ask the examiner to do something for you, always give them an exact idea of where your head is at, because you'd actually made the diagnosis. It's only when I didn't flip over to the next image that you continued to talk.
Yeah. Yes,
so I think just keep that in mind, that before you ask the examiner for anything in the exam, unless you're absolutely lost, always give them an idea of what's going on in your mind, what you're thinking about, what could be the possible differential, and how is it playing out in your head essentially. This case, you handled it really well. I would have liked you to comment on the cervicothoracic sign in this and just call it positive, but you gave me the final diagnosis, so I don't think they're going to worry about the nitty-gritties. But do you think the cervicothoracic sign is positive in this or negative?
Positive, because it's clear above the clavicle. It's not anterior.
I'm sorry?
I can see that the lesion, it's clearly delineated above the clavicle.
Can you delineate it for me, please?
Like this.
Okay, 1 second. So this is, you call a cervicothoracic sign positive when you can't see the borders of the lesion just above the clavicle actually. So there's because what happens is that the anterior, that's why I asked you this question. The anterior mediastinal mass is the anterior mediastinum, or the anterior part of the lung. It would end before, it would end.
The clavicle, yes.
Right? So if something is protruding into the neck, it should not be outlined by the lung. So anything other than the thyroid in the anterior mediastinum, if it's going into the neck, would give you a cervicothoracic sign positive, which means that you can't delineate the edges of the lesion, which you actually can't on the right side. If you notice carefully, yes, you can, you are actually connecting the lateral aspect of the neck to the lesion. And there's a very subtle opacity, which you can see here. And on the left side, however, I'm contradicting myself, but that is because thyroid lesions are special and you can see them to some level above the clavicles. So
if it was above the clavicle, do we call it positive or negative?
If you can't see it above the level of the clavicle, you call it positive, thereby placing it into the anterior mediastinum. Because anterior mediastinum, there's no lung tissue there. The only exception to the anterior mediastinal mass, which can be seen above the level of the clavicle, is a thyroid mass, which can only be seen for a small amount above the level of the clavicle.
Yeah, I know this, but what is it positive if it was above the clavicle or if it was below the clavicle?
It's positive if it's an anterior mediastinal mass and you cannot see the lateral aspect of the lesion, like you can't see it on this side, right? So that's when you call cervicothoracic sign positive. When you cannot see it, when you can't see the lateral margin of the mass above the level of the clavicle, and it's an anterior mediastinal mass. But the exception to this rule is thyroid masses, which is very beautifully depicted in this image.
Thank you.
Okay, so the last one second. The last one is actually a case of herpes encephalitis, which is why I was having fun with you on it. So the diffusion restriction happens because of the edema. So if you start to see the patient in a little bit of a late stage, you can not always necessarily, you can see a T2 shine through, and there are areas of restriction peripherally, which you can still appreciate. Which is why, you actually got the diagnosis on the first set of images itself. You talked about the involvement, you talked about how it spared the basal ganglia, what you're worried about, but then you sort of dug your own grave by just following one sequence and saying, this is not it, then I'm not sure what it is. So if it was to be a low-grade glioma, it would not have spread this much, right? For something to have become this big, you automatically would think that it has a high mitotic index and, the grade of the lesion has increased. So once the grade also starts to increase, a component of diffusion restriction would have started to come in even in a high-grade glioma, right?
Yes. So it can do no diffusion restriction, depend on the age of the stage of the...
And a high-grade glioma also, why would it specifically spare the basal ganglia in this case, right?
Yeah.
Okay. So, yeah, I think that about covers it all. I think you handled the cases well. I think I gave you a good, I told you the feedback as we went along. Be more definite, be more sure of what you're saying, and your content well. So whatever you're saying, just stick to your guns, essentially, moving forward in the exam.
Okay. Thank you. Thank you so much. That's very, very useful. Thank you so much.
Thank you so much, Dr. Aarushi. And candidate 2, please stay for us for a moment. And Dr. Aarushi, very good set of cases. Thank you again. And we want you to have more sessions with us in the near future before the March exam. Is that possible?
Yeah, sure. We'll definitely figure that out, sir.
Sure, thank you. You don't need to call me sir. Actually, Dr. Aarushi and me, we passed in the same session, that is March, and we attended the convocation together. So it's better you don't. And the rest of the candidates also should not call me by sir. It's better if you call me Sandeep or Dr. Sandeep. That's good enough. Regarding the cervicothoracic sign, I understand there's a bit of confusion. Even I was confused during my last year's preparation, and I still sometimes continue to be confused by that particular sign. So Dr. Aarushi has given a very good description. Yeah.
And show them this for...
Yeah, in the meanwhile, what I have done is just to reinforce I have shared a video by Dr. John Curtis. There's a video of cervicothoracic sign very well depicted by Dr. John Curtis himself on his YouTube channel, that is Radiology Masters. I have shared it on the group, which you all can go through later. And yeah, Dr. Aarushi, over to you.
So I'm just going to explain it in brief. If we say a cervicothoracic sign is positive, we are trying to call it an anterior mediastinal mass, right? Anterior mediastinum would not have any lung parenchyma, because of which, why do we see something on a chest X-ray? Because of a difference in the densities. So if there is no lung parenchyma, which is of a very low density as compared to the soft tissue, we should not be able to appreciate the lateral borders of the mass, right? So a positive sign would mean that it's an anterior mediastinal mass. The differentials would be a cystic hygroma, a left superior vena cava, a right aortic arch, or a thymic cyst. Okay. For example, this case. But a thyroid is the only exception to this rule. in which you can actually see the lateral margins of an anterior mediastinal mass above the level of the clavicle. However, the giveaway in this would be there would be a degree of tracheal compression in a mass that big, which is involving the thyroid. So as you can see, there is compression of the trachea even in this case, which is the same case that I've shown you guys actually, right? So this is what a normal anterior mediastinal mass would look like, cervicothoracic sign positive, wherein you can't see the borders. This is actually a cervicothoracic sign negative, in which you can see the borders. So if you were not seeing the pathology on the right side and you were only seeing the pathology on the left side, you could have called it a posterior mediastinal mass if there was no tracheal compression, and no one would have penalized you for it.
Nice. Thank you.
Thank you so much, Dr. Aarushi. Just before we complete the session, what marks out of 8 would you give candidate 2?
I'm a really lenient examiner. I'll give you a 7.
Same here. Actually, I've
Thank
also
you.
marked candidate 2 as a 7
thank
out
you.
of 8. So candidate 2, very well done. Just few tips as a third person who's just observing the session. So the good points about you is you're confident, you're loud and clear, your approach is very good, and you do not panic. So both the candidates today did not panic. So they were ready to take on the questions from both the examiners. Your speed is optimal and your knowledge is also good. So these are the plus points about you. The few negative points about you is that you should make it a point to scroll through the entire case before coming
Yes.
to a diagnosis. And if, or for example, in that Poland syndrome case, it is always better to ask the examiner. If you are confused whether those are the set of images that you've been provided and there are no further images, you can just ask the examiner, is this the entire scan? Do I scroll further? So that you can do. And one more thing, that is to complete the case, complete the management, and then wait for the examiner to show you the next case. Most of the examiners in the FRCR viva will not prompt you, so they might not even tell anything in between, and you have to complete the case. They'll just wait for you to complete everything and they'll move on to the next case. So you have to be ready for such kind of examiners as well. And think about differentials. So both the candidates today, always be ready with the pertinent differentials. Even if you're very sure about the diagnosis, be ready with the differentials. One very important point, which already has been told to you by Dr. Aarushi, look outside the box. So, and this is something I learned from a candidate while attending last year's power course by Dr. John Curtis. So when you attend Dr. John Curtis's power course, he actually makes it very specific that everyone has to put the cameras on. He wants to see everyone. So that's a good thing. So what happens, we get to see the examiners as well as the candidates. So there was one candidate who had a habit of going back once he or she, it was a he actually. So once he's described everything, he used to go back and scroll through the entire case once from a different point of view, from a different perspective. So to maybe look outside the box, so to say. So that is something which even I did. So you can describe your findings once with a close-up view and then sit back a bit, maybe a few centimeters behind, and then see if there are certain findings which you've missed. So that is something which candidates can do. And one very important thing which I follow in my day-to-day practice as well as any exams that I give is that symmetry is your friend in radiology. If there's anything which you're finding that there's something wrong with the symmetry, if the right side doesn't look exactly like the left side, look into it further. So that Poland syndrome, if you would have just picked up that there's something wrong with the symmetry, you wouldn't have wasted too much time on it. So other than that,
Yes.
you did very well. Both examiners,
you so
1 and 2, Dr. Aarushi and Dr. Wala, if you want to add something else, please do. Else, we shall
Please,
complete today's session.
Dr. Sandeep, please. There is one case I see in my viva. It's difficult case, but I would like
Yeah,
to share
I'll just stop you before that. I'm very sorry, Dr. Wala. I
one
think it's
case
better
only.
not to discuss our own cases because there is a non-disclosure agreement by RCR. So we're not supposed to share our cases. Is that so, Dr. Aarushi? Do you confirm this?
Yeah, I'm sure you're probably right about this. I mean, maybe not on a public forum like this.
Exactly. So maybe you can share
It's
it on
being
the group.
recorded, and you're going to update it somewhere. So yeah.
Exactly. So this will be on YouTube. I'm very sorry about that, Dr. Wala, but we'll definitely like to hear your specific point, but we can share it on the group. I'll add you to the group and
Okay.
we'll discuss that further. Anything else to add, Dr. Aarushi, or can we wrap up the session for today?
I'm good. I think I've told them everything about this viva.
Indeed. Thank you so much to
Thank
everyone.
you so much. Thank you.
Thank you for
Thank you. We
attending.
really
And,
appreciate your effort.
I think Sunday I won't be able to conduct the session as I'm traveling. I'm not sure if the hotel Wi-Fi will be able to sustain the session. So Sunday there will be no sessions. And next week I'm traveling to UK, and I'll let you know on the group regarding the timings on what I'm supposed to do from there. So it totally depends on the timings and the Wi-Fi that I have over there. So please bear with me during the next week at least. Thank you so much, everyone. Good night for today.
Thank you.
Thank you, Dr. Sandeep.